think about this for a second. Nearly half of all adults right here in the U.S. have high blood pressure.
Yeah, it's a really staggering number.
And it often just sort of flies under the radar, doesn't it? Like
That-
a silent condition that can cause some serious damage to your cardiovascular system.
Absolutely. And we're not just talking heart attacks or strokes, though those are obviously huge. It's a major player in other vascular problems too, like peripheral artery disease, PAD.
Right, PAD. That's what we really want to dig into today, the connection there.
Exactly. Hypertension is, well, it's incredibly common, and its impact on vascular health specifically is often underestimated. So today we're going to explore that, really drawing on the latest from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition,
Yeah, pulling out the key stuff from the textbook, but making it, make sense for everyone.
trying to understand it from that vascular surgery angle.
Our goal here is really to get a clearer picture of this really common condition, see how it ties into diseases like PAD, and look at how it's being diagnosed and managed right now.
Okay, so where do we start? The sheer scope.
Yeah, let's start there. Just how big a deal is hypertension?
It's enormous.
Mm.
The 2017 guidelines from the ACC and AHA, the Cardiology and Heart Associations, they really shone a light on this. Nearly half of U.S. adults.
Half. Wow.
And beyond just how many people have it, it's the leading cause of death related to cardiovascular disease. And second only to smoking is a preventable cause of death overall.
That's pretty sobering stuff. And I understand it doesn't hit everyone equally.
No, it doesn't. Your chances of having it go up quite a bit as you get older. And unfortunately, it affects Black Americans more frequently than white Americans.
Okay.
It's also worth noting, women with hypertension seem to face a slightly higher risk of related cardiovascular events compared to men. And that increased risk is even more pronounced for Black women compared to white women.
Okay, so widespread, but with some important differences depending on age and demographics. Now, how directly does high blood pressure link up with other heart and vascular issues, like specifically PA?
Oh, the link is definitely strong and complex. There was a big study, Caliber, that gave some interesting insights.
What did that find?
Well, it suggested that higher diastolic pressure, that's a bottom number in your reading, seemed to have a bigger effect on abdominal aortic aneurysms, AAAs,
Okay.
whereas a higher systolic reading, the top number, that was more strongly linked to PP, heart attacks, angina, certain kinds of bleeding.
Huh, that's interesting. So different pressures might affect different vascular problems more?
Seems that way. And a big analysis back in 2019 really drove home the aneurysm risk. It found hypertension increases the relative risk of getting in AAA by like 66%.
66%.
Yeah, pretty significant. And they even worked out how much the risk climbs for every, say, 20-point rise in systolic or 10-point rise in diastolic.
Wow.
Now, focusing just on PA, the Framingham Heart Study, that classic long-term study, looked at people with claudication, leg pain when walking,
Right.
and it showed a clear link. Higher systolic and diastolic pressure meant a greater risk of developing PAD, defined that way.
And that lines up with other studies too, right? Though I think sometimes the exact pressure number that's most important seems to depend on how you measure PAD.
That's a good point. Studies that use the ankle brachial index, the ABI.
Comparing arm and ankle pressure.
Right. Those often point more towards systolic pressure being the key driver for PA, defined by ABI. But, when you look long-term, like Framingham again, and also NHA-NE's, the National Health Survey, they found that both untreated and uncontrolled high blood pressure basically doubled the risk of PA. Didn't matter if you defined it by claudication or ABI.
So the bottom line is high blood pressure is bad for PA risk, full stop.
Pretty much. Elevated blood pressure contributes, period. But the link between overall cardiovascular disease, including PA, and that top number, the systolic pressure, that seems to be the strongest connection we see consistently.
And this growing understanding is really what led to the guidelines changing, right? I remember when the numbers were different.
Absolutely. It was a major shift. As we learned more about the risks, even with blood pressure levels we used to call pre-hypertension.
Yeah, that always felt like a weird waiting room category.
Exactly. There was a big push to redefine what high blood pressure actually is. The old JNC7 guidelines had, normal pre-hypertension, stage 1, stage 2.
Right.
Then came a really crucial study called SPRINT, the Systolic Blood Pressure Intervention Trial.
What did SPRINT show?
It looked at people with high blood pressure and other heart risks, but not diabetes. And it compared aiming for a systolic pressure under 120 versus aiming for under 140.
Okay, a lower target versus the standard at the time.
Right. And the findings were so striking, they actually stopped the trial early
Really? Why?
because the group aiming for that lower target, under 120, had significantly fewer major cardiovascular events, heart attacks, strokes, heart failure, and fewer deaths overall.
Wow, that's pretty definitive. But I seem to recall the pictures may be a bit different for people with diabetes.
It is, yeah. The ACCORD trial focused specifically on patients with type 2 diabetes.
Okay.
And in that trial, aiming for the lower systolic target, under 120, didn't show the same overall benefit for the main combined outcome they were looking at.
Okay.
However, they did see benefits in certain subgroups, particularly for stroke risk. The stroke reduction was similar to SPRINT, and when researchers combined data from SPRINT, ACCORD, and other trials in meta-analyses,
Yeah.
they consistently find that even blood pressure in that 120 to 129 systolic range or 80 to 84 diastolic carries a higher risk compared to being truly below 1280.
So all that evidence piled up and led to the big 2017 OSEOI guideline update,
Exactly. That's what lowered the diagnostic threshold for hypertension.
which logically meant more people were suddenly classified as having it.
It did. The prevalence in the U.S. jumped by almost 14% overnight, based on the new definition.
Okay. But did that mean a huge jump in people needing medication?
Interestingly, no, not really. The overall recommendation for starting drug therapy only went up by less than 2%.
Huh. How does that work?
Well, a lot of the newly classified people were in stage 1, where lifestyle changes are the first step, and meds are only recommended if their overall cardiovascular risk is high.
Right.
But there was a significant increase in recommendations for medication specifically for people in that systolic 130, 139, or diastolic 80, 89 range.
Got it. So more people labeled hypertensive and those in that slightly higher zone are now more likely to be considered for medication, especially if they have other risk factors.
That sums it up well. The big takeaway here is, hypertension is super common. It's a major risk for atherosclerosis, especially leading to PFA. And these two things together, high blood pressure and PT, they really ramp up the risk for serious problems. The recent guidelines reflect this better understanding.
Okay, so definition changed, huge problem, clear links to vascular disease. Let's talk diagnosis under these newer guidelines. How's it actually done?
Well, first off, the definition itself is the major change, like we said. The ACA uses that lower threshold now. It's worth noting, though, that this isn't universal. European guidelines, for instance, still use a higher in-office reading to define hypertension.
Oh, interesting. So not quite a global standard yet. And the way we measure blood pressure is also a huge focus in these new guidelines, isn't it? Like doing it right?
Absolutely critical.
Yeah.
The ACHA really emphasizes that a diagnosis shouldn't be based on just one reading. It should be an average of multiple properly taken readings while seated over at least 2 or 3 separate visits.
Okay, multiple readings, multiple visits.
And beyond that, the U.S. Preventive Services Task Force actually found that ambulatory blood pressure monitoring.
That's the one where you wear the cuff for 24 hours.
Exactly. That 24-hour monitoring was a better predictor of future cardiovascular events than just the readings you get in the doctor's office.
That makes sense. Avoids the white coat effect.
Right. So because it's a better predictor, these out-of-office measurements, either with the 24-hour ambulatory monitor or just regular home blood pressure monitoring, are now recommended.
For what exactly?
To confirm an initial diagnosis made in the office, make sure it's really sustained hypertension, and also to track how well treatment is working over time.
Okay, so you get a more realistic picture, and this helps tell apart the different sort of flavors of hypertension.
Yeah, exactly. It helps distinguish between sustained hypertension, where it's high both in and out of the office, masked hypertension, where it's normal in the office, but high outside.
Ooh, that sounds tricky to catch.
It really can be. And then there's white coat hypertension, where it's high in the office, but normal outside.
How do the risks compare for those?
Well, masked hypertension is actually pretty serious. It carries a similar, maybe even slightly higher risk than sustained hypertension, so it needs to be treated just as aggressively. White coat hypertension, on the other hand, seems to have a risk profile closer to, say, well-controlled hypertension. So maybe lifestyle changes and just keeping a close eye on it might be enough initially.
So getting those measurements right, both in and out of the office, is crucial for figuring out the real risk. What are the absolute key steps for getting an accurate reading in the clinic?
The guidelines lay out 6 key things. First, patient prep. Relaxed, seated quietly for 5 minutes, feet flat, back supported. No caffeine, exercise, smoking for 30 minutes before. Empty bladder, no talking.
Okay, sounds simple but easy to mess up. What else?
Second, use the right technique. Validated monitor, support the arm at heart level, use the correct cuff size, that's huge. Note if you need a special size.
Cup size is important. Got it.
Third, measure correctly. First visit. Check both arms. Use the arm with the higher reading going forward. Take at least 2 readings a minute or 2 apart.
Both arms first, then stick with the higher one. Makes sense.
Fourth, document it properly. Systolic, diastolic, time of last BP med dose. Fifth, average those readings at least 2 readings on at least 2 visits.
Okay.
And finally, sixth, tell the patient their readings, verbally and in writing. And especially for patients with PD, checking both arms is really important.
That is a thorough checklist. And the out-of-office monitoring, how does that usually work in practice?
So you've got the 24-hour ambulatory monitoring we mentioned with the automatic cuff, or more commonly for long-term tracking, home BP monitoring.
Just using a regular home machine.
Yeah, a validated automated one. Ideally, that stores readings. The usual advice is take 2 readings, a minute apart, morning before breakfast and evening before supper. And the guidelines actually give diagnostic cutoffs for ambulatory monitoring too.
Oh, yeah. What are those?
An average over 24 hours of 125/75 or higher, an average while awake of 20/80/80 or higher, or an average during sleep of 11/5 and 65 or higher. Any of those would meet the criteria based on ambulatory monitoring.
Okay, so different targets depending on when it's measured. Now, once someone is diagnosed, what do we actually know about the cause? Is it all lifestyle?
For most people, maybe 90%, it's what we call primary or essential hypertension, meaning we don't know the single exact cause. It's thought to be a really complex interplay between genetics and environmental factors over many years.
Like what sort of factors?
Things like aging, being overweight or obese, having a family history, race or ethnicity, like we mentioned, Black or Hispanic ethnicity has higher rates. Then diet high salt, low potassium, lack of physical activity, drinking too much alcohol. All these things contribute to that gradual rise in pressure over time.
So a mix of biology and lifestyle. But you said 90% is primary. What about the other 10%?
Yeah, in about 10% of cases, there's actually an underlying identifiable medical condition causing the high blood pressure. We call this secondary hypertension.
And can that be fixed?
Sometimes, yes. If you can treat the underlying cause, the blood pressure might come back down or be much easier to control. That's why a really thorough history and physical exam are so important.
What kinds of things would a doctor be looking for specifically? Clues for secondary causes?
Well, beyond the usual history, lifestyle, family history stuff, definitely a careful review of all medications, prescription, over-the-counter supplements, everything. Table 14.3 in the source lists common drugs that can raise BP.
Okay. And the physical exam?
Listening for unusual sounds, bruits in the abdomen, could suggest renal artery issues. Feeling the thyroid gland. Checking pulses carefully in arms and legs. Differences could suggest things like coarctation of the aorta.
And routine lab tests?
Standard stuff includes a cholesterol panel, blood sugar, CBC, thyroid test, TSH, electrolytes, kidney function, creatine GFR, a urinalysis, and an ECG. These give a baseline, check for organ damage, and might offer clues to secondary causes.
When would you do more specialized tests?
Those aren't for everyone. But if the history, exam, or initial labs raise red flags, then yeah, you might check hormone levels like renin, aldosterone, cortisol, medinefrins, maybe uric acid, or imaging like an echocardiogram or an arterial duplex scan. Table 14.4 lists key examples of when to suspect secondary causes, like symptoms of aortic coarctation, sleep apnea signs, clues for renal artery stenosis, or primary aldosteronism.
What about when blood pressure is just really hard to control, even with meds?
Yeah, that's resistant hypertension.
How is that defined?
It's basically when your blood pressure stays above your goal even though you're taking 3 different types of blood pressure meds, including a diuretic, usually a long-acting CCB, and an ACE inhibitor, or ARB, all at the highest doses you can tolerate. Or, if your BP is controlled, but it takes 4 or more meds to get there.
Okay.
The AHA updated the criteria slightly in 2018. Table 14.5 outlines it. When you see resistant hypertension, you really need to circle back and look hard again for secondary causes. Also need to make sure the patient is actually taking the meds and rule out persistent white coat effect.
Why is identifying it so important?
Because people with resistant hypertension have roughly double the risk of cardiovascular events compared to those whose hypertension is controlled. It's a high-risk group.
Definitely important to identify. Okay, so we've covered the scope, diagnosis, causes. Now let's dive into that link between hypertension and atherosclerosis, the plaque buildup that causes PAD and other issues. It sounds complicated.
It is. It really is. We've known they're linked for ages, but the exact molecular and mechanical ways they influence each other still not perfectly understood, mostly because atherosclerosis itself is so complex: genes, behavior, environment. other conditions like diabetes, high cholesterol, it all mixes together.
You mentioned renal artery stenosis, narrowing of the kidney arteries as a secondary cause. How does that fit with atherosclerosis?
Well, often that narrowing is caused by atherosclerosis plaque buildup in the renal arteries. And interestingly, studies show a pretty significant chunk of people with PAD who get angiography also have renal artery stenosis.
Do they often go together?
They do. And when blood flow to the kidney is reduced, it kicks the body's renin-angiotensin-aldosterone system, the RAAS, into high gear.
The blood pressure control system.
Right, which raises blood pressure, but it's also thought that this RAAS activation directly promotes and worsens atherosclerosis itself. It becomes a vicious cycle.
Ah, I see.
There's even some animal research suggesting that the oxidative stress from low kidney blood flow can drive atherosclerosis even without high cholesterol being involved.
So high blood pressure can be both a cause and a result here. What have animal models in general taught us about this interaction?
They've been really valuable. We have genetic models, surgical models, diet-induced models. They've shown that hypertension can definitely trigger inflammatory pathways that lead to plaque forming and growing in mice arteries.
Okay.
And some, though not all, models show that lowering blood pressure can reduce the amount of atherosclerosis.
Yep.
The inconsistencies just highlight how complex this relationship really is. It's not always a simple one-to-one effect.
And that renin-angiotensin system, the RAAS, seems central to this whole thing.
Absolutely. That's one thing that comes through pretty consistently in research. Messing with the RAAS has a direct impact on atherosclerosis.
Remind us quickly how that system works.
Sure. It involves renin from the kidneys, angiotensinogen from the liver. They interact to make angiotensin delay. Then an enzyme called ACE converts that to angiotensin II.
Okay. And angiotensin II is the key player.
It's a major one. Potent vasoconstrictor narrows blood vessels. Also tells the adrenal glands to release aldosterone, which makes you retain salt and water. Both raise blood pressure.
Yeah.
And mouse studies clearly show. Give them constant angiotensin II, they get more atherosclerosis. Block the RAAS system with drugs like ACE inhibitors or ARBs. You can reduce atherosclerosis, sometimes even independent of the blood pressure change itself.
So it's not just about the pressure, the system itself seems involved in the plaque buildup.
Exactly. Which is why those drugs targeting the RAAS are so important in treating both hypertension and cardiovascular disease.
What about the connection with high cholesterol? How do they interact?
Well, we see they often occur together in people. And there's evidence that in folks with high cholesterol, their blood vessels actually have more receptors for angiotensin II.
Oh, interesting. So they might be more sensitive to it.
Seems that way. They tend to have a bigger jump in blood pressure in response to angiotensin II. Interestingly, statins, the cholesterol drugs, can actually blunt that exaggerated response.
Yeah.
And animal studies suggest that combining RAS blockers, like an ACE inhibitor, with statins can be better at reducing atherosclerosis and controlling blood pressure than using either drug alone. Synergistic effect.
Okay, makes sense. Finally, what about the endothelium, the inner lining of the blood vessels? How does that play into hypertension and atherosclerosis?
Yeah, endothelial dysfunction is strongly linked with hypertension. It's often considered a very early step in atherosclerosis developing.
What does the endothelium normally do?
A healthy endothelium is crucial. It helps blood vessels relax and dilate properly, which helps control blood pressure and prevents plaque from sticking and building up. It releases substances like nitric oxide, NO.
Nitric oxide is key for relaxation.
Very key. It's a major vasodilator. In hypertension, the endothelium often doesn't respond properly. It can't dilate as well when it should. And if you have less available nitric oxide, it can create this pro-inflammatory, pro-thrombotic environment. Perfect conditions for atherosclerosis to start.
So hypertension damages the endothelium, which then makes atherosclerosis worse.
That's generally the thinking. And mice engineered so they can't make endothelial nitric oxide. They develop higher systolic blood pressure.
But does endothelial dysfunction cause hypertension in the first place? Or is it the other way around?
That's the million-dollar question, and the data is a bit mixed. Some studies suggest children of hypertensive parents show signs of endothelial dysfunction early on, suggesting it might come first. Other studies haven't found a clear difference, especially in young adults. So more research needed there to really nail down the sequence.
Okay, so it's a really intricate web: hypertension, atherosclerosis, RAAS, cholesterol, endothelium, all tangled together. Given all this complexity, how do we actually manage hypertension? What's the overall approach?
The main goal is pretty straightforward. Lower the blood pressure to reduce the risk of atherosclerosis and all the bad things that come with it. Heart attack, stroke, PD progression, death.
How to do that?
Usually it's a two-pronged approach.
Right.
Lifestyle modifications and pharmacotherapy, meaning medications.
Okay.
For people diagnosed with stage 1 hypertension, that's the 130-139 systolic or 80-89 diastolic range, the decision to start meds often hinges on their overall cardiovascular risk. Doctors use risk calculators like the ASCVD risk score to estimate their 10-year risk. If it's high, usually above 10%, meds are generally recommended along with lifestyle changes.
Lifestyle changes first, always, right? How much difference can they really make?
They can make a significant difference, and they have tons of other health benefits too. Weight loss is a big one. There's a pretty direct relationship. You lose about 1 millimeter mercury in systolic pressure for every 1 kilogram, or roughly 2.2 pounds, you lose.
Okay, that can add up. What else?
Diet is huge. The dietary approaches to stop hypertension is well studied. Lots of fruits, veggies, whole grains, low-fat dairy, low in saturated fat. That alone can lower systolic BP by maybe 11 points in people with hypertension.
11 points is a lot.
It is. Reducing sodium intake, increasing potassium is also key. And then there's exercise. Regular physical activity, aerobic like walking, jogging, swimming, resistance training like weights, even isometric stuff like hand grip exercises all contribute to lowering blood pressure.
And alcohol.
Moderation is important. Cutting back if you drink heavily can also lower BP. Table 14.6 in Rutherford's gives specific targets for sodium, potassium, exercise frequency and duration, and alcohol limits, and estimates how much each change might lower systolic BP.
So lifestyle is the foundation, but medication is often necessary too. How are we doing overall with getting people's blood pressure controlled with meds?
Well, the NIH data shows, awareness is pretty high. Many people are prescribed medication, but the actual control rates getting people to their goal BP are lower than we'd like.
And specifically for people who also have PD.
Getting their blood pressure controlled is really important. It's been shown to slow down the progression of ischemia in their legs, improve endothelial function, even help their functional status, how well they can walk. But paradoxically, studies show that patients with PAID are often less likely to be on optimal medical therapy, including good BP control, compared to patients without PAID. There's a gap there.
Why might that be?
It's not entirely clear. Maybe some lingering concerns about lowering BP too much in legs that already have poor circulation, though newer data suggests most BP meds are safe. Maybe just complexities of managing multiple conditions.
Right. There was some early thought that maybe certain types of blood pressure drugs were better for PA patients, wasn't there?
Yes, some initial smaller studies hinted that maybe calcium channel blockers, CCBs, or ACE inhibitors might have an edge in reducing cardiovascular events in PAID.
But did that hold up?
Not really in the big trials. Large studies like LHAT and INVEST and subsequent meta-analyses, they didn't find any significant differences between the major antihypertensive classes when looking specifically at PAD outcomes.
So no magic bullet class for PAD specifically.
Doesn't seem like it based on current evidence.
And what about that concern you mentioned, lowering blood pressure too much, potentially hurting limb perfusion in PAD?
It's a valid theoretical concern that doctors consider. The LHAT study did show that having hypertension itself was linked to more PAD hospitalizations, procedures, and deaths. And the INVEST study actually suggested a sort of J-shaped curve in PAD patients.
Meaning
That both very low systolic BP and very high systolic BP were associated with worse cardiovascular outcomes. Too low wasn't good either.
So there might be a sweet spot.
Possibly. It suggests we need more research to really figure out the optimal BP targets specifically for PAD patients, especially now with these lower overall targets from the 2017 guidelines. It's an area needing more study.
Okay. So general principles for starting pharmacotherapy, who gets meds and what's the goal?
Right. So lifestyle counseling for everyone with BP over 20/80, because the risk starts climbing even then. Meds are generally initiated for stage 1 hypertension if their 10-year ASCVD risk is 10% or higher, or for anyone with stage 2 hypertension, which is 14/90 or above.
Then the target.
The general target for most people is less than 13/80. There might be some benefit for aiming even lower, like less than 120 systolic for certain high-risk individuals based on SPRINT, but less than 13/80 is the standard goal.
Okay. What are the main first-line medication choices, the go-to drugs?
There are 4 main classes considered first-line: thiazide diuretics, calcium channel blockers, CCBs, ACE inhibitors, and ARBs, angiotensin receptor blockers.
How do you choose between them?
It should be individualized. You think about the patient's other health conditions, their age, race sometimes plays a role based on trial data, potential side effects, cost, how likely they are to stick with it.
Did the LHAT trial compare these?
Yes, all het was huge. It compared a thiazide, chlorthalidone, a CCB, amlodipine, an ACE inhibitor,
Hmm.
sinopril, and also an alpha blocker, doxazosin, which kind of fell out of favor after the trial.
What did it find?
It found that the thiazide diuretic, chlorthalidone, was superior in preventing heart failure compared to the others, and similar or superior for preventing stroke. The alpha blocker was clearly inferior for heart failure.
Okay.
And these patterns generally held up in black patients, where ACE inhibitors were found to be less effective than the CCB for preventing heart failure and stroke in that specific trial population.
So Alhat suggested maybe thiazides have a slight edge, at least for certain outcomes.
That's one interpretation, yeah.
Yeah.
And some meta-analyses support that long-acting thiazides like chlorthalidone might be optimal first-line agents for many. But really, all four main classes significantly reduce cardiovascular risk compared to placebo.
Should you start with one drug or jump to two?
For stage 1 hypertension, especially if they're not too far above the goal, starting with one drug plus lifestyle might be enough. But for stage 2, where their average BP is more than 20 points systolic or 10 points diastolic above goal,
Yeah.
it's often recommended to start with two first-line agents from different classes right away. Combination therapy often gets people to goal faster and sometimes with fewer side effects than maxing out a single drug.
But watch out for blood pressure dropping too low.
Definitely,
Yeah.
especially in older adults or people prone to dizziness. And generally, you avoid combining drugs from the same class or classes that work very similarly, like an ACE and an ARB together. Usually not recommended, though there are niche exceptions with diuretics or CCB sometimes.
You mentioned other health conditions guiding the choice. Can you give some examples?
Sure. If a patient has stable ischemic heart disease, like angina or a history of heart attack, beta blockers are usually considered first line, along with maybe an ACE or ARB.
Okay. What about heart failure?
That depends heavily on whether they have reduced or preserved ejection fraction, how well the heart pumps. But typically involves diuretics, ACE inhibitors or ARBs or ARNIs, beta blockers, and sometimes aldosterone antagonists. Specific guidelines for that.
Stroke, kidney disease, diabetes.
After a stroke or TIA, you usually start standard therapy once they're stable. For chronic kidney disease, CKD, or diabetes, if they have protein in the urine, albuminuria, an ACE inhibitor or an ARB is strongly preferred because they help protect the kidneys.
And PAD. We said no single best class, right?
Right. For PAD patients, since no class has shown superiority specifically for PAD outcomes, you choose the antihypertensive based on their other conditions. Do they also have heart disease, kidney disease, diabetes? That guides the choice.
Okay, that makes sense. Let's maybe quickly run through the main classes again, hitting the key points, how they work, main uses, big side effects. Thiazide diuretics.
Okay. Thiazides work in the kidneys, block sodium reabsorption, make you excrete salt and water, lowers blood volume and pressure. Often work well in low renin states like in older adults or black patients. All hat showed benefits for heart failure stroke prevention. Relatively low cost. Can decrease calcium excretion, may be good for bones. Less effective if kidney function is poor. High salt diet or NSAIDs reduce efficacy. Side effects: low potassium, low sodium, high uric acid, gout risk. High calcium, maybe slight rise in blood sugar, erectile dysfunction. Ideal first line for many, but use cautiously in elderly or if renal artery stenosis is suspected.
Got it. ACE inhibitors.
ACE inhibitors block the angiotensin-converting enzyme, reducing angiotensin II production. This relaxes blood vessels, lowers pressure. Synergistic with thiazides. Good evidence for improving endothelial function, preventing cardiac remodeling. HOPE trial showed big benefits. May reduce atrial fibrillation recurrence. Preferred in CKD with proteinuria, diabetes with proteinuria, but, as all had suggested, may be less effective for stroke HF prevention in black patients without those comorbidities. Common side effect: dry cough due to bradykinin buildup. Less common but serious. Angioedema, swelling. Caution in PAD due to potential for acute kidney injury if bilateral renal artery stenosis is present. Can cause high potassium, contraindicated in pregnancy.
Okay. Angiotensin receptor blockers, ARBs.
ARBs block angiotensin II from binding to its receptor, AT1 receptor. Similar effects and benefits to ACE inhibitors: vasodilation, lower pressure, often used if someone can't tolerate the ACE cough. Life trial showed benefits with losartan. On target showed telmisartan was non-inferior to Rammer, an ACE, but combining them increased adverse events. Generally similar efficacy to ACEs, maybe slightly lower risk of cough and angioedema, also standard first line. Also recommended for proteinuria, diabetes, CKD, may reduce AF recurrence, also contraindicated in pregnancy.
Calcium channel blockers, CCBs.
CCBs block calcium entry into smooth muscle cells and blood vessel walls and down to heart muscle. Two types: Dihydropyridines, like amlodipine and nifedipine, mostly affect blood vessels, potent vasodilators. Non-dihydropyridines, verapamil, diltiazem, affect both vessels and heart, slowing heart rate and contractility. Dihydropyridines might be good for salt-sensitive folks or NSAID users, non-dihydropyridines. Caution with slow heart rate, heart block, reduced ejection fraction, heart failure. Some hint they might help claudication in PID, but not guideline recommended for that. Likely equivalent to thiazides, may be better than ACE-ARBs for stroke HF prevention based on some data. Dihydropyridines common side effect. Ankle swelling, edema. Non-dihydropyridines. Constipation, especially verapamil.
Beta blockers, you said their role changed.
Yeah, they block beta-adrenergic receptors, slowing heart rate, reducing contractility, lowering BP. Used to be first line for just hypertension, but multiple studies showed they're generally inferior to the other main classes for preventing stroke and overall CVD events unless the patient has another specific reason to be on one, like coronary artery disease or heart failure, especially reduced ejection fraction. Different types exist, selective versus non-selective. Side effects, fatigue, depression, reduced exercise tolerance. Caution with asthma, COPD, significant heart block. But the old worry about worsening PB, largely debunked. They're considered safe in PP now.
Okay. What about loop diuretics?
Loops, like furosemide imitinide, work on the loop of Henle in the kidney. Very potent diuretics, great for removing large amounts of fluid quickly. Main use is for volume overload states like heart failure, advanced CKD, cirrhosis. Less potent as pure antihypertensives compared to thiazides for typical hypertension, but cause fewer metabolic issues like high blood sugar or uric acid. Main side effects relate to volume depletion, electrolyte loss, especially potassium, magnesium, potential allergic reactions, sulfa.
Potassium-sparing diuretics.
These work later in the kidney tubule, collecting duct, to block sodium channels, like triamterene, amiloride, or aldosterone receptors, spironolactone, eplerenone, we'll get to those. The sodium channel blockers have very weak BP lowering effect alone, mostly used as add-on therapy with thiazides to counteract potassium loss. Need caution in kidney disease or with other drugs that raise potassium, like ACE-ARBs, because of hyperkalemia risk.
And the aldosterone receptor antagonists you just mentioned, spironolactone, eplerenone.
Right, these specifically block aldosterone's effects. Aldosterone makes you retain sodium and water and lose potassium. So blocking it helps lower BP and prevents potassium loss.
Yeah.
Very useful in primary aldosteronism, too much aldosterone, and often added for resistant hypertension or certain types of heart failure. Eplerenone is more selective than spironolactone, so less likely to cause hormonal side effects like gynecomastia, breast enlargement in men. Main risk is hyperkalemia, especially with kidney disease or other potassium-raising drugs. Need to monitor potassium and kidney function.
Okay, almost there. Alpha blockers.
Alpha-1 blockers, like prazosin, terazosin, doxazosin, relax blood vessels by blocking alpha-1 receptors. Use decreased significantly after all HAT showed doxazosin was inferior for heart failure. Main use now is often in men who have both hypertension and BPH, enlarged prostate, as they help with urinary symptoms too. Side effects: dizziness, orthostatic hypotension, BP drop on standing, fatigue. Non-selective alpha blockers are used for pheochromocytoma.
Centrally acting alpha agonists.
These, clonidine methyldopa, work in the brainstem to reduce sympathetic outflow, lowering heart rate and relaxing blood vessels. Methyldopa is one of the preferred agents for hypertension during pregnancy. Clonidine is generally considered a later-line agent, maybe fourth-line, because it can cause significant sedation, dry mouth, and importantly, rebound hypertension if stopped abruptly. Methyldopa can also cause orthostatic hypotension, fluid retention, rarely liver issues, or hemolytic anemia.
Direct vasodilators.
Hydralazine and minoxidil. They directly relax arterial smooth muscle. Potent BP lowering. Generally reserved as later-line agents for resistant hypertension because they often cause reflex tachycardia, fast heart rate, and fluid retention, so usually need to be given with a beta blocker and a diuretic. Hydralazine can cause a drug-induced lupus syndrome. Minoxidil is very potent, used for severe resistant hypertension, especially with renal impairment, but causes significant fluid retention, tachycardia, and hirsutism, excess hair growth.
Last one, renin inhibitors.
Aliskiren is the main one. Blocks the very first step in the RAAS cascade, the action of renin itself. Its long-acting efficacy similar to other first-line agents when used alone. Looked promising in combination therapy, but the Altitude trial showed increased adverse events, stroke, kidney problems, hyperkalemia, when combined with an ACE or ARB in high-risk diabetic patients, so that combination is now generally contraindicated by the FDA. Side effect profile and that warning have limited its use.
Wow, that's a huge arsenal of medications, and it sounds like research hasn't stopped there. There are even newer, more experimental MHs being looked at.
Absolutely. especially for that really tough-to-treat resistant hypertension.
Mm-hmm.
There's ongoing interest in device-based therapies. One is carotid sinus baroreceptor stimulation.
How does that work?
The carotid sinus in your neck has receptors that sense pressure and help regulate BP. The idea is to implant a device, sort of like a pacemaker, that electrically stimulates these receptors to trick the brain into thinking pressure is high, causing it to lower sympathetic activity and blood pressure.
Has it worked?
Early devices, like the Rio system, showed it could lower BP in phase 3 trials, but didn't meet safety goals mainly due to procedural risks like nerve injury, so limited use. Newer second-gen systems are smaller and hopefully safer and are being studied now, like in the Barostim therapy trial. Still investigational mostly.
And the other big area of device research was renal denervation, right? Bleeding nerves around the kidney arteries.
Yes, exactly.
Huh.
Based on the idea that overactive sympathetic nerves in the kidneys drive resistant hypertension. It's a minimally invasive catheter procedure using radiofrequency energy or ultrasound to essentially zap those nerves.
What happened with that? I remember hearing a lot about it.
Yeah, there was huge excitement initially. Early, smaller studies like the Simplicity HTN 1 and 2 showed really impressive blood pressure reductions. But then the larger, more rigorously designed sham-controlled trial, Simplicity HTN 3, failed to show a significant benefit compared to a sham procedure plus medical therapy. And other large trials had similar disappointing results in FLE.
Why the difference?
Still debated. Maybe issues with the procedure itself not achieving complete or consistent denervation, patient selection, the complexity of resistant hypertension that the ACHO concluded there wasn't enough evidence to support it back then. However, research didn't stop. Newer technologies and techniques for denervation are being developed and tested in ongoing trials, some with more promising recent results focusing on specific patient groups or using different methods. So the story might not be over, but it's not standard practice yet.
Fascinating. It really shows how managing hypertension is still evolving. Our source material, Rutherford's, even includes some treatment algorithms, doesn't it?
Yes, they provide helpful visual guides. There's a general algorithm for treatment and follow-up. Start with lifestyle, assess BP, initiate meds based on stage, and risk, monitor, adjust. Then more specific ones, like for primary prevention in people without other comorbidities, showing those first-line choices. One for patients with stable ischemic heart disease, highlighting beta blockers first, and one for heart failure, emphasizing the core drug classes for that. They're good summaries of the guideline recommendations.
This has been incredibly informative, really digging into hypertension from that vascular perspective. If we had to boil it down, what are the absolute key takeaways you want people listening to remember?
I'd say 3 main things. First, hypertension is incredibly common and has a huge impact on vascular health, definitely contributing to PD development and worsening. Second, getting the diagnosis right is crucial. That means proper measurement technique, multiple readings, and considering out-of-office monitoring.
Okay.
And third, management has to be personalized. It starts with lifestyle for everyone, but often requires medication, chosen from a wide array of options, guided by the patient's overall health profile and other conditions. And importantly, our understanding and the guidelines are always evolving with new research.
It's a dynamic field, which leads to a final thought for you, our listeners. Given just how complex hypertension is, how it intertwines with everything else, and all this ongoing research into novel drugs and devices, what kind of innovative approaches do you think might truly revolutionize how we treat high blood pressure in the coming years? Think about the challenges we still face, like resistant hypertension or ensuring adherence, and the potential breakthroughs that might be on the horizon. Definitely something to ponder. Thanks for joining us for this deep dive.